Welcome to Inside the Studio, the official podcast of the Texas Heart Institute at Baylor College of Medicine. I'm Dr. Joseph Rogers, and together we'll explore the ever-evolving world of cardiovascular care. In each episode, we bring you conversations with the people shaping the future of heart and vascular health, cardiologists on the front lines of patient care, surgeons performing groundbreaking procedures, and scientists leading discoveries that will change medicine for generations. We'll also highlight perspectives from international leaders and community voices who share our commitment to preventing, diagnosing, and treating heart disease. Whether you're a physician, a researcher, a patient, or simply curious about the latest in heart health, this podcast is your inside look at innovation, education, and care at the highest level. So let's step inside the studio. Hi, I'm Dr. Joe Rogers, and I am the director of the Texas Heart Institute at Baylor College of Medicine, and I'm joined today by a good friend and colleague, Mehdi Razavi, who has given grand rounds at THI on some of the work that you're doing to sort of change the way we think about common problems in clinical electrophysiology. And specifically, we talked a little bit today in grand rounds about the work that you're doing with very novel and innovative atrial defibrillation, and then this story about electroconductive hydrogels and ways that those might be used to treat ventricular arrhythmias in particular. So Mehdi, thanks for joining us in the studio today.
Thank you very much, Dr. Rogers, for having me. It's my honor and privilege to be here. Probably one of the biggest driving factors behind my work, my lab's work, my team's work is this concept of imperceptible defibrillation. As you know, in the field of cardiac electrophysiology, cardiology, malignant ventricular arrhythmias, atrial arrhythmias, when they are going in the condition called fibrillation, where the entire heart is quivering at the same time, you really can't pace the heart. The only way to reset, if you will, the electrical activity of the heart is to shock it. Well, a shock is although incredibly effective, by far the most effective, it has a significant price associated, namely physical pain. Yeah. And that discomfort, unfortunately, because arrhythmias can become often are mercurial and somewhat unpredictable, so the shocks become the same too. So patients, not only is the pain an issue with them, but the unpredictability that this can suddenly happen at any moment. This is not trivial. This is a significant and real problem, and as I've said before, to a point where we know, I have family members who are in the psychiatry field, that patients have PTSD with this, that this really is a barrier to acceptance of this technology. Also that, leads can fracture. You can get multiple shocks because of technical issues. So the concept of imperceptible defibrillation has been something of a holy grail in our field. And I'm not going to be the first one to say that this is an idea that the germs were with us. But now we're in an environment, a time and a place where we finally have the tools. We have the tools to bring together the ability to take that current of energy that you're basically injecting current, massive amounts of current, into the heart to reset it. That's how defibrillation works. Well, now we have the tools to disperse that current so you can give it in a very synchronized fashion, but you don't need to have one output. You can deliver it from multiple either pacing nodes or conductive highways that we have created. When you do that, you can disperse that energy to levels that are truly imperceptible, that are at levels that a pacemaker would have. And as we know, patients with a pacemaker don't know that their heart is being paced for the most part. That is imperceptible. And so ultimately, our goal is to take these pieces of technology that we discussed, put them together, starting with the atrial defibrillation, and ultimately bringing it to the field of ventricular defibrillation. Atrial defibrillation is somewhat more forgiving. You can have atrial fibrillation and, it's not a medical emergency. So that's where we've started. And what we've shown pretty conclusively, and this data should be coming out hopefully in the next, in the future, near future.
Good.
That you can pace terminate atrial fibrillation, provided you have multiple sites of pacing in the left atrium. So you need about 4 to 6 areas to pace, and then with the right sauce and ingredients, you can terminate AFib in a significant number of these patients. The ventricle is different. The ventricle, not only is it less forgiving in terms of it has to happen right away, but also it's thicker tissue. So injecting that current into the ventricles is much more challenging than the atria, which is paper thick. That's where the conductive hydrogels come in. So what you have is these conductive hydrogels provide the conductive highways that up to now we didn't have. Think of them as being extensions of a standard pacing lead, but that they can go into regions that are the size of capillaries and interdigitate with the regions of scar and delay conduction that cause the arrhythmia. So by controlling those areas using these conduction highways with the conductive hydrogels, and then powering those conductive highways with the wireless nodes, you have total control of the cardiac electrical architecture. And you're doing that without having to ever shock the patient. You're doing it all through controlled pacing outputs. And it's, the term AI and machine learning, you can't give a talk without using those 2 letters. But it does, in this case, it really is something that probably will lend itself to this technology.
Sure.
Because you have the ability now to see exactly in real time. I'm pacing, I'm seeing what kind of responses I'm getting, and that can plug into a machine learning system that says now you should pace from different areas. And we have data to support this. So that comes together. You have the actual hardware with the wireless pacing, you have the highway with the conductive hydrogels, and you have the technology now to program these. And you put it all together, and you have a situation where we've shown now that defibrillation, at least for now, atrial defibrillation, can happen with pacing outputs.
So let me push a little bit on what you know or what you would speculate on atrial defibrillation. And I want to start with this idea of personalizing care. You would have to imagine that atrial pathology is not uniform, that there are a variety of different conditions that could cause predispose one to atrial fibrillation. So you've suggested that somewhere between 4 and 6 electrodes might be the right number. Do you know that? Do you have a good sense about where those electrodes need to be positioned, and how does the atrial geometry or atrial scar pattern influence what you think you'll need to do with the atrial electrodes?
Excellent question. And it absolutely plays a huge role with that. That's why what we started doing computer modeling before we started going into our preclinical and ultimately into clinical studies. Because with the computer modeling, we could plug in variables such as conduction velocity variables, such as scar burden, all these different things that determine essentially your predisposition to these arrhythmias with atrial fibrillation. Turns out most of those features, those electrical conductive features, can be gleaned if you do have 6 electrodes sitting on the outside surface of the heart. As long as you know where those electrodes are relative to each other, when they pace and they sense, you can figure out, the conduction velocity here is better or faster or more diseased. But the substrate it manifests itself. Mm-hmm. Then as you're pacing, you also can see what in real time is the response. And the response to pacing is almost like the fingerprint. So if you think of every arrhythmia or every heart as a different person, what we see as we're pacing is our fingerprinting of that substrate. Because when you pace, it's not just pacing, you're seeing if I'm capturing that local electrical activity of the heart, and if I am capturing it, at what rate am I capturing it, how long is it taking me to capture it, and these are the variables that when you plug in, you have the booking number of that certain specific form of atrial fibrillation for that individual patient. So yes, that's critical.
Are you using, or are people using digital twins now as a platform to begin to take what you know about human anatomy, physiology, and the therapies that you're employing, and do this basically in a computer environment rather than in a laboratory animal environment, for example?
The term actually wasn't when we started this digital twin. The first time I heard this was about 2.5, 3 years ago. So probably not then, but in fact, we are kind of doing that. What we're doing is even our computer models are actually based on human clinical procedures and data collected during human cases that were done in a standard fashion, nothing experimental with those, but we have the data that looks at the conduction velocity and what the substrate was. So yes, in a way we have done that, and I guess you can call that a digital twin or not.
Yeah.
But yeah, the data that we use is based on actual clinical human data.
And then regarding the hydrogels, Mehdi, so I love the story about the way that you might apply it to ventricular tachycardia and to the treatment of it. And it makes perfect sense, and I think you explain it in such a accessible way to people who don't do this every day. The other thing that strikes me about the hydrogels, are the potential that you could use them as a pacemaker. As almost like a really interesting pacemaker lead. And the challenge, of course, is with the strategies we use today is we really don't replicate the native conduction system. But this potentially could. I mean, do you see a utility for the hydrogels in that application, or do you think it will mostly be for arrhythmia management?
I think the number one thing that every innovator has to do before they come on a podcast is to promise themselves they're not going to use the term platform technology. But I'm going to break that, because really the hydrogels are in a way a platform, because I absolutely believe that the conduction system pacing is going to be enhanced by this. In fact, it's if you will, an extension of a standard pacemaker lead. And it can actually go in areas that harbor the native conduction system. That's why the ECGs that we showed in our work were so much more similar to the ECGs that we right now have, even in our standard conduction system pacing procedures. So yeah, it absolutely is there, and we are very actively looking into that.
Great. Well, Mehdi, listen, thank you so much. I know that you have a busy clinical day. We'd like to let you get back to work, but thank you for coming to the studio today, and we look forward to having you back sometime in the near future to hear about how things have changed and to get an update on the work that you're doing. So thank you very much.
Thank you for having me.